Well, good afternoon, or good morning, or good evening, depending on where you are. You are at the Department of Epidemiology series of seminars, and this week's seminar is great as an introduction. It is of Dr. Alfredo Morabia. It's wonderful to have you, Alfredo.
Thank you.
Dr. Morabia, it's not the first time speaking for our department and in this series, but he is a professor of epidemiology at the Barry Commoner Center for Health and Environment of the City University of New York and a professor of clinical epidemiology at the Department of Epidemiology of Columbia, the Columbia Mailman School of Public Health. He is also a PI of a still ongoing World Trade Center heart cohort study. It was not stopped by our current government, it continues. And he is, of course, a major historian, I would say the major historian of epidemiology, and has written books about that. Has been also the editor-in-chief for 10 years of the American Journal of Public Health. Dr. Morabia, it's wonderful to have you, and particularly in this time, you have taken a topic that may be relevant for us. What if public health had to be built from scratch? Revisiting 19th century debates. Dr. Alfredo Morabia, please take the floor.
Thank you. Thank you very much, Bert. I mean, it's always a pleasure for me to come and give a talk, even if it's virtually. I would have preferred in person, but anyway, and always a great honor. Let me share my screen. So do you see my screen? Just to start.
Yes,
Okay.
yes.
So I have to thank, first of all, Carrie Nadeau and Sonia Hernandez Diaz, because they gave me the idea of the topic of my talk. I was going to speak about something very different, but they sent me an email asking, can we talk about public health research and where we're going? And that gave me the idea of preparing this talk. I have a caveat immediately because I have 40 minutes. So I don't have the time to do all the shadow boxing, and explaining every statement that I have. I need to be blunt sometimes. But when I say I'm being blunt, it means I could give you a much more nuanced explanation, but all things considered, this is what I think. So let's go into this topic of what would how could we conceive a public health built from scratch with the first blunt statement. And this is that, I mean, I don't know if you're familiar with that, but except for the last 150 years, for all of human history and all over the planet, there's no concept of disease, as specific entities that exist independently of the symptoms they can create in people. This is a new concept for almost all of human history. Medicine and public health focus on health. And health is an individual concept, is a state of equilibrium between the environment and the organism of an individual. And you see here the traditional, I mix the Chinese and the Greek model, which is the humoral model that extends until the 19th century, where you see that in order to be healthy, you need to have a balance of the dry, the wet, the hot, the cold, and the different element. And same thing for the yin and the yang. So the health is the focus, and it's easy to think that. To think that it is because it was 25 100 years ago, and they didn't have bacteriology, and they didn't have, you know, a notion of disease. But when you think Hippocrates, you know, 2,500 years ago, still extremely influential in his thinking. Or the Yellow Emperor, I mean, the medical one is 5,000 years ago, but the inner classic of traditional Chinese medicine is also about 2,000 years ago, a little bit more. So these were major thinkers, and if they chose to focus on health rather than on sickness, it was on purpose. And 2,500 is a lot of years. Bert, do you think that in 4,526, people will still be using causal models?
Well, yeah, that's a good question. Thank you. Thank you.
I
Yeah.
think so. I think so because it's an elegant response to an eternal problem. But when you look forward, you see the distance, 2,500 years. So these people need to be taken very seriously as having chosen their framework rather than having been forced to do it by lack or ignorance. And actually, the model of focusing on health rather than disease is still present in the main public health view of the 19th century, which is called the sanitarian. And it's sanitarian because it's from sanitas and it means health. And the aim of this, first, we'll compare them with the bacteriologists, but the sanitarian view is to protect the root causes of health, transform the environment, the living conditions in order to protect health and by the same time, you know, avoid everything that can actually interfere with this individual equilibrium. And it's a whole concept. It's a vision of a whole healthcare system. And here I'm showing Max von Pettenkofer, who was the first ever professor of public health. It was called hygiene then. And it was in Munich, Germany. And he was, you know, a dominant figure of public health in the 19th century. And the way he conceived public health in Munich in particular was really a comprehensive view in which public health had to deal with everything that has to do with human life, you know, air, clothes, housing, crowding. I mean, his writing are absolutely gorgeous about all those questions. Everywhere, you know, people live, homes, factories, etc. And then the Institute of Hygiene, which we would call today a School of Public Health, was there to generate the evidence from science. And then they brought the economy, the statistics. Then he created Public Health Journal to disseminate this information and to influence policy. And he delivered because the impact on the vital statistics of Munich, which was one of the most disease-ridden society in Europe, you know, are absolutely striking. You know, their mortality overall declined. Typhoid fever, which was an important cause of death related to lack of hygiene, also diminished very fast. The sanitarian had one major weakness. The theory on which they were basing all their policy was inherited from Hippocrates, never been demonstrated scientifically. That was a huge problem. They believed that you know, this interaction with the individual equilibrium, healthy equilibrium, was caused by some form of air pollution, something that you know, stink, was in the air, inhaled, and would actually create a sickness. But that's where this interaction came in with individual predisposition. Two people who smelled this, who inhaled the same air, one could fall sick and the other one not. And that's where individual predisposition came in. And there were hundreds of them. Here, I'm just look at their numbers in order to imagine that if you need to run a model with all those variables, you end up with a single person for in every version of the model. So that's the problem. They could not test, using epidemiologic approach, their theory. They believed it worked because what they could see is that their theory, that stench was associated with disease and with ill health was actually actionable. This is a cartoon that shows the local board of health searching for where the smell is, but then they would remove the smell, and this would lead to healthier cities. And actually, the sanitarians were the major, the dominant figures in medicine and public health throughout the century. They were the leading scientists. And they had a concept of health. Here I'm being blunt, but a healthy city smells good. That was, and in order to do that, you need sewers, you need water closets, you need water, you need everything that, housing and streets, etc. You need to have a transformation of urban life, and they delivered. It happens here, you have some of them that probably many of you don't know them or never heard of them, even though, again, they were the leaders of in the in the 19th century. You have Lemuel Shattuck. This is not far from you, since he had these famous reports on the Sanitary Commission of Massachusetts. Then you have Rudolf Virchow, a hero of social epidemiologist, because he wrote that medicine is just politics with other means, a major clinician and pathologist. You have William Farr, who created the foundation of our vital statistic system, invented international classification of disease. All of them miasmists. Edwin Chadwick, who is especially known for his report on the sanitary condition of the laboring population of 1842, but he has also a compilation of his work under the health of nations, and I'm going to talk about it a little bit later, and that's why I'm showing it. And it's not Ishiro Kawashi's book, even though Ishiro has also a book on this name, which is excellent, but I'm talking about him. And of course, Max von Pettenkofer. And the sanitarians don't believe that bacteria can suffice to cause disease. That's very important. Even though they may agree that there exists some bacillus and bacteria once they have been discovered and demonstrated, they still think that there is an interaction between this germ and the environment. And here you see Max von Pettenkofer's model represented, which, the bacteria, the bacillus, if it's cholera, may be in the feces, but it's not pathogenic. It needs to go in the ground to have a contact with the soil. If it's a short contact, it's just going to be stinking, a stench. But if it's long enough, a miasm is going to come out and cause disease. So, of course, this looks kind of ridiculous from our perspective because we're really serious about finding real causes. But again, it's actionable. It's actionable. You separate the bacteria from the soil through water closet, which are sanitary installations, through sewers, etc. And then there's no cholera. And that's why they believe so much in their theory, even though it's never been tested, and this is going to be the reason for their loss, as we're going to see in a few minutes. The other, it's a younger generation of researchers. They are bacteriologists. They believe in contagion, they believe in microorganisms, search for them and find them. And of course, Robert Koch, Louis Pasteur, you know them, they are our heroes. And what they did was absolutely fantastic in terms of their achievements, but they have a completely different vision of public health. They focus on specific root causes of diseases, on the microorganisms. That's what they are after, isolating, destroying the microorganism, whatever the context in which it takes place. And bacteriology will bring enormously to the health of our population. First of all, it meant cleaning the water because the water was a source of transmission of many of these bacteria. You know, all the wastewater treatment, the filtering of water in sand. Then these are things that the sanitarian neglected with their air pollution perspective. Antiseptic surgery is a direct consequence of that. Pasteurized milk, vaccines. I mean, a great feast of successes in terms of improving of human health. And more importantly, for what happened in the case of cholera, they explained it. There was a bacillus that was the single and unique cause of it, and they had a solution, you know, isolating people, closing markets, etc., limiting physical interaction. And John Snow, Ignaz Semmelweis, the epidemiologists, were part of this tradition. They believed in contagion, even when they had not seen the microorganisms yet, because bacteriology has a model that is um, that lends itself to epidemiology. You have one cause, the microorganism. You can compare groups that are allegedly exposed or not exposed, and derive evidence whether you got the right cause or not, which was not possible in the sanitarian approach because they had this interaction with the individual predisposition. So what happened in the sanitarian view was knocked out in 1892 by an epidemic of cholera in Hamburg. And if you haven't read this book, I mean, do it. It's the greatest book I know about an epidemic somewhere. But this is a map. These are streets, etc., of two cities. There is Hamburg, there is Altona. And it's actually one city. This dark line here is a border between Prussia, which is Altona, and the Free State of Hamburg, which is in the north. But it's not a wall. It's just a kind of street that you can cross. It's a conurban place. And you have the river Elbe, which provides the water that people drink, use for washing, use for everything. And in 1892, there is a cholera epidemic in Eastern Europe. People move to Hamburg in order to take the boats and go to America. And there they contaminate the river Elbe. The Hamburg was following the sanitarian views. They didn't filter the water. They put it in cisterns where it just, the hard parts settled down, and then they sent the water as such to the faucets of the people. Whereas Altona was following Robert Koch of Berlin's opinion, in which, you need to filter the water. Their water was filtered in sand before going into people's faucet. And the consequences are dramatic. It's a huge epidemic. It kills 1.3% of the population in Hamburg, twice as much as, the usual or the worst cholera epidemic in London, for example. It's huge, but it's all in Hamburg. There's no death in Altona. So it was kind of a demonstration that the bacteriological view was correct. But there was even something more. It was a test because Europe was obsessed by the risk of a epidemic from the east that would devastate it. And they were building, stations to actually screen people entering in different parts of Europe. But there, Koch showed that he was able to protect Europe. He was able to block an epidemic, whereas Pettenkofer and the sanitarian were not able. And this was the key moment, and in which the situation turned completely. Sanitarians you were abandoned from a day to another, never criticized, never. It was just a movement in one direction without looking back. And before, we keep praising bacteriology, we need to know that it's also meant, by focusing on microorganisms, it's meant completely bypassing everything that sanitarians wanted to improve. Air pollution, filth, misery, occupation. This was over. And I want to show you one evidence of this, even though I'm being blunt here. But here you have the German Empire. You have the north. Here is Prussia, Berlin, Koch. And here you have Bavaria, Munich, Maxford, Pettenkofer. And you have these are statistics about infant mortality, highly public health related outcome. In Bavaria, you see it's much higher than in Prussia to start with. But here comes Pettenkofer, and the impact is absolutely dramatic. I mean, it reduces very fast. Whereas in Prussia, when, Koch comes a little bit later, but there's no such an improvement. Clearly, there's not so much interest in the public health improvement of the cities and people's life that the sanitarian had. Again, this would need much more development in order to be explained, but the data is excellent data. This paper provides official statistic from 19th century, and I mean it. So, but here is the situation at the end of the 19th century. You have a victory by knockout of the sanitarian view, which is changes the root causes of health compared to the bacteriological view, which is the root causes of diseases. And this is where the difference lies and will have an impact on all the next development of public health. And I love to show Pettenkofer and Koch like this, one next to the other one, because when you look at Pettenkofer, he can only be in his office at the institute. He has his life around him with all these pictures and things, and he looks outside and there is sun entering in the room, etc. Koch has his table with his microscope. He's totally focused. This could be in Berlin, could be in Cairo, can be in Delhi. He's got everything in a suitcase, and wherever he is, he creates the situation, and that's what his interest is. So, what are the consequences of the knockout of the sanitarian and the thriving of the bacteriological view in at the end of the 19th century? This is from Birth, is a slide he loves to see, to show. You have the increase in life expectancy across the years. You have the 19th century, the 20th century. It's a feast. I mean, the change in life expectancy is clearly an enormous success, not only of medicine, but also in changing of our mode of life. And again, don't misunderstand me. I don't underestimate the achievements of bacteriology and the fight against disease. They were absolutely used. But there are a lot of things we need to look at. First of all, public health became the poor relative of the healthcare system. I mean, when you see the national health expenditure statistic, public health is in else, you know, and and uh, and in these statistics, public health is essentially CDC, FDA, state and local health department, and they represent maybe 2-3% of the $5 trillion that go into hospital, doctors, and drugs. Okay, so clearly, public health has a very small, marginal role in the system. We'll see that these statistics should be taken very cautiously. The other thing, and I'm sure you know this graph, it's so telling that everybody shows it, but these are the spending per capita for healthcare, and these are the life expectancy that we just show you the graph. At some point, the system reaches a plateau. We can spend more and more, we don't get more life expectancy, and we are here spending way more than any other and not doing much better. So it's an inefficient system. The other thing is that the amount of waste of resources is just, mind-boggling. Because I had as an editor an advisory board of state health officers. They were mostly from red states, and I offered them at some point to make an issue of the journal on the topic that they would select, and they selected waste in healthcare system. And that's one of the graph that one of the article they invited shows. Those are billions, and between clinical inefficiency, misprevention opportunities, overuse, administrative waste, excessive price, fraud and abuse, 125 billion. That's the budget of HHS of the whole health public health in the national health expenditure. Altogether, you get to 1.5 trillion of waste in the 5 trillion budget. So their ideas, they're, mostly Republicans, they, dedicated to public health. We should take this money and put it somewhere else, and in something that is directly public health. So, and on the other hand, we have a public health system that is extremely efficient, even though, we can criticize a lot, but compared to the other one, and that is cheap. I mean, this slide, I challenge anyone, to tell me that this country, does not trust public health when we see that these are this is the coverage of the COVID-19, primary series full COVID-19 coverage in people 65 year and plus. The average on the country is 95%. The worst achieving state is Arkansas with 83% of coverage. In 2019, before the pandemic, you would have asked any expert, if we have a mandatory vaccination campaign, what's going to be the proportion of American vaccinated? They would say 45%, 50% on the base of, we got 95%. Everybody knew 65 year plus were at higher risk. Everybody knew that the vaccine worked and was safe, and the work was done everywhere. So I don't know if today, now that the vandals took the handles, if I may say, of the healthcare system, we could achieve such a result, but we did it during the pandemic. And so that shows it, and it's public health because the vaccines are in the warehouse of the pharmaceutical industry. To make them vaccination You need to have all the public health system that brings them from there to the arms of the people who, in this case, voted for their arm in favor of public health, and you have to register, etc. So it's a public health success with very few harmful consequences. All right. So we have a system, I think, inherited from the bacteriological area that have influenced all of our healthcare system, and that has reached a limit. It reached a plateau, and it's the right moment to consider we should not reconsider the choices we did 150 years or 100 years ago. And 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 how would this look? Uh, it would mean reorienting our schools and our activity from specific diseases. Just look at the name of our different specialty in epidemiology into dealing with the way people live and communicate, etc., including medicine, but as a last resort. And frankly, I know a bit of the discussion about the future of public health. I don't think we're uh, as advanced. We actually look far behind where ecologists, environmentalists have been thinking about sustainable cities, etc. Again, I cannot be blunt on that because it's not a literature that I know too well. And I know there have been some paper in Nature Medicine last year and that have addressed this. But it's a really stimulating perspective to understand how would public health fit in these new cities, and in particular the role also of AI in there. So, Bert, sorry for that. I think our schools are really schools of public diseases. I try to make the point about it, and uh, and we should really become schools of public health. And Veritas, you should not get rid of Veritas. Now we need it more than ever. But maybe adding Sanitas, and it's a nice rhyme, would be something to consider. So in this process, there are three elements of everything that can be considered that I want to bring to your attention. For me, they are important, and some of them, I mean, cost, health monitoring, education, engagement, and communication. Cost, frankly, I'm a public healther from the heart. I'm interested in saving life, in reducing inequities. I've never been very fascinated by the economy and the cost, but maybe we should think about it twice. Because if you want to reconfigure the system, you have to know where the money goes. And nobody knows really. I mean, there's this great book by a colleague from University of Chicago, Colleen Grogan. She was also an editor of the journal about where the money goes. And it's not possible that with 3% of expenses in public health, our society would survive. Societies have survived hundreds of years without medicine, but no society can survive more than a few weeks or months without public health. So where is these expenses which exist? And she shows that, you know, those are not considered as public health, but they should be. The EPA, the House and Urban Developments, lead control, etc., Department of Energy. If you take only the Farm Bill from the USDA, the Food and Nutrition System, SNAP, the Supplemental Nutrition um, Program, its budget, 100 billions, is equivalent to the whole budget of HIV, of the Health and Human Service, so 100 billion. So that's the type of things that we should be aware. We should know how much are we spending today in some things that are related to public health. How much should we be able to reorient and use maybe more efficiently? And maybe that's something I say with a lot of sadness, but maybe we get a greater consensus on showing that public health saves lives, then save money, than that it saves life. And that's what, those state health officers try to explain to me. And recently, I mean, just a few days ago, I saw that the McKinsey Health Institute has come out with a report called The Health of Nations. It means Chadwick, and they don't cite him, and they don't cite Ishiro either. But the idea is there, is that if you improve health, you could save a lot of money. You know, um, like more labor participation, more productivity, etc. This boosts our GDP. And I think that people thinking about that, you may find them in your cafeteria. I read this book by Glaser and Cutler. It's a very pleasant book. I don't agree with everything. They have a lot of very blunt statement, but when they say the roots of our medical dysfunction lie in a system that is focused on private health rather than public health, and on care for the sick rather than promoting health, this is blunt, and I could have written. So they are in your cafeteria, the same as the work of Raj. I mean, they are all around you. Just go and talk to them. And and I knew these papers by Max von Pettenkofer, The Value of Health. It's actually the two papers that Henry Sigris, the great historian, had translated in English, and there Max von Pettenkofer sells his program to the municipality of Munich by showing how much money they will save. Okay, that's how he was convincing the politician, the lawmakers, to follow his recommendation. I really recommend those two lectures. They are really very didactic and great. The second point, which I think, and CHS is disappearing, or it's really weakened. Lots of our health monitoring tools are being abandoned. Health monitoring is indispensable for public health. There's no health monitoring. There's no public health without health monitoring. We need to have this, and since the 17th century with the bills of mortality, that's when modern public health appears. We need health monitoring to know what are the needs to evaluate our intervention. And we are not doing great currently. But you have here, maybe also in your cafeteria, you have Rochelle Walensky, who developed a whole thinking of how we could develop a health monitoring system when she was at the CDC. So another person to talk to. And we, at the end of COVID-19, we had this issue of AJPH, where, nobody knows how many cases of COVID-19 there have been in the US. We don't know. We don't have a measure of asymptomatic cases. In Spain, and this is a project that Miguel Hernan worked with, and in the UK, they did much better. So there are examples, and we could be inspired by them. The last and the third element, which I think is essential for public health, and this is what we've learned over the last century. We need to educate, train public health thinkers. This is what we're doing. We need to continue, but the engagement with the community is key. It needs to go both ways. We need to know how the communities perceive their needs and perceive um, the adequacy of what we propose, and they need to know what we find in terms of science. There must be a dialogue here, which is dynamic, which is formalized, and finally, we need to allow our boldest students, the one who don't only want to study and to understand the world, but to change it. they need to have access to those theories, those framework that link science with the social praxis. And I'm sitting intersectionality because it's one I know, and we talked a lot about it in the journal. But it's something that should be incorporated in our new perspective on public health. And I think you're very lucky to have Bisola, Dr. Ojikutu, as health commissioner for Boston. Another person, I don't know if she's in the cafeteria, but you should talk to. So let me wrap up. What if, and the what if is there so that we don't have to talk about whether it's realistic or not. I think I gave you the impression that for me it's extremely realistic. 3 more years of what we have had last year, we'll have to rebuild and to build something new. But so what would be the option? In 1900, there were two options: one centered on health and one centered on disease. I'm being blunt, but this is really what I think. The sanitarian approach was discarded, never disapproved, and the anyway, and bacteriology has had huge successes, but it has reached a plateau after 100 years of implementation. So building a public health from scratch could mean a healthcare system focusing on the root causes of health, with tertiary care as being the last resort. And one last point, and it would be another seminar, of course, but we've learned from the mistakes, from the huge catastrophes associated with public health over the last 100 years. We've learned that the public health approach, in order to be effective, needs to have at least four characteristics. It needs to be fair for justice. It needs to be democratic and participatory. Otherwise, it's not legitimate. It doesn't convince, it doesn't have support. It needs to be universal for efficiency. We should not exclude anyone, not exclude Republicans, not exclude undocumented uh, uh, persons. We should include everyone. And if we don't get at least 95% of the population behind you, we're not efficient. And finally, it needs to be science-based because that's important for accuracy. All right. That's what I had to say. Thank you.
Dr. Morabia, thank you very much. This was quite an overview on the first place and a deep dive in not only the 19th century, indeed. It has major implications for our thinking now. Thank you very, very much. From studying root causes of diseases to root causes of health is your proposition. Do you allow us to ask you a few questions or make comments? Is that okay for you?
Of course, of course.
Please, let's invite people who would like to ask a question. You can do it in the chat, or you can do it by putting your hand up or just starting to speak. That is, as far as I'm concerned. Yes. Shuji, I wanted to ask you already. You had a comment in the chat, and so
Yes.
please go ahead.
Right.
One
Thank you so
reminder,
much.
please go ahead.
Yes,
Dr.
thank you so
Lino.
much for great lecture. I totally agree. And I think agree with you. We have to focus on, everybody rather than just sick people. But no matter how I try hard, it's very difficult. I'm also a pathologist myself, so my discipline focus on disease. That's why I bring up Barco here. It's a father of pathology. So how we can change our focus? That's our struggle.
So thank you for the question, which is of course very hard. And uh, Shuji, the good thing of giving a seminar at Harvard is that you can give some ideas and you have lots of people much smarter than you. If they catch them, they will transform them and make with these ideas things that I could even not imagine, you know. So I my role is just to bring to your attention the fact that major changes can occur. You know, what we find today as normal, focusing on diseases, and we've been doing this for, all of the time public health has been effective in the 20th century, we could change our orientation. And we may be forced by the situation in general, but a school like Harvard School of Public Health can do such a thing, can actually reorient, bring the people, bring the expertise, they exist, they are around, and rethink the project, because that's where the leadership is going to come. I cannot answer your question, but because I don't have this vision, but I'm sure that if you have a working group on this issue, you'll come out with uh, fantastic solutions, and I can't wait to see them.
Thank you. Thank you very much. Um, any other questions or comments? Can I take the liberty to ask you? So we have a division of labor, of course, in around health. Namely, we have the schools of diseases, namely schools of medicine, and we have schools of health, public health. Is it not a more reasonable approach to try to integrate those two approaches and see whether there can be a link between, on the one hand, focusing on determinants or focusing on disease? That's my first question. And my suggestion would be that epidemiology can play a real, very important role of it as the queen science of public health, but also in some senses the queen science of clinical medicine. What do you think of that?
So, of course, I mean, I'm not saying that public health should exclude medicine and medicine should exclude public. I'm not saying that. I think it's been a huge mistake of the sanitarians to consider bacteriology as an enemy. They
Yes.
should have integrated it. But it was the political environment then that was telling them that the bacteriologists were against the reform that they wanted to do,
But you're not
and
worried that we would make the same mistake again if we follow your suggestion?
yeah, but I think there's a question of balance. Currently public health is really extremely small in the system, and don't have the importance it could have. We saw during COVID, I mean, the response and the vaccine was medicine and was the pharmaceutical industry and was all that, but to transform it into what it has been, it needed public health, and public health cannot be improvised. So that's one thing. The other thing is that we need to have a real picture of how we deal with health, how we protect health. And currently, it's not only CDC, FDA, and the local health department. There's much more than that. There's the whole way we live in. And I, I would imagine that the specific role of medicine and public health in the new system should be based on what the priorities will be, based on our reflection. But of course, integration is important.
Thank you. Thank you very much. I have, I think, a final question, perhaps for time reasons. Li Wai Li, Ji Wai Li, please, would you ask your questions yourself? Could you do that? Or shall I read it for you?
Yeah, I can read the question.
Please go
Thanks.
ahead. Go ahead.
Yeah, great.
Please.
Thanks, Dr. Morabia.
Yeah.
I think just on the previous points around intersection of medicine and public health, I was wondering if you could comment on recent successful examples of social medicine. I've been working at community health centers. It seems to be one pragmatic apparatus, but curious to your thoughts around other examples of quote unquote social medicine.
So can you give me what do you mean by social medicine so that I'm sure I'm in.
Yeah, that's a good question. I mean, I think I am coming from a practitioner perspective. Community health center embodies, substantive social services, helping folks with, navigating the health system or social system, getting insurance and things like that. So yeah, so just wondering that's my perspective on social medicine.
Yeah. No, I got it, and I understand. And frankly, I discovered this aspect of medicine late into my tenure in the journal. And during the last year I was there, I tried to really develop the intersection between community medicine and public health and understand better its importance in our system. Again, I think this is a very important aspect of our system, which does not receive this financial and infrastructure support that it requires, and especially when you go in more rural areas, etc. But again, I'm completely in favor of that. What I'm trying to say in my talk is that we need to rebalance the whole system in order to give public health and social medicine, as you defined it, is part of public health in our country. Their real role, impact, and efficacy. That's what I was trying to say. But thank you.
Thank you very much. Yes, we are, as you know, we have a hard stop because our students have to go to other places and so on. But I would like to take the opportunity to take two more things. One, I would invite you to our next seminar, which is in a week. Dr. Ron Kessler will speak about online panels for epidemiologic research, mainly perhaps from the field of psychiatric epidemiology. How can they be used? It will be an in-person in Kresge, for those of you who know Kresge 502, but it will also be online, so you can choose what you want to have. Dr. Kessler, next week, same time. And then my second point is to thank Dr. Alfredo Morabia very, very much for an inspiring, I think, and seminar that will also, I'm quite sure, lead to discussions and perhaps may even influence the strategic discussion that we have in our Harvard School of Public Health indeed in the coming months. Thank you very, very much, Alfredo. And I can already invite you for a next seminar, but we will say the date then, okay? Thank you very much.
Thank you, Bert. Thank you.
See you
It's
all.
a great pleasure for me also to be here. Take care. Bye-bye.
Thank you. Bye-bye.